Healthcare Alliance for Patient Safety for making this program possible. As healthcare providers increasingly adopt innovative technologies such as telehealth, patients are receiving care in completely different ways. From primary and preventative care to monitoring patients in rural communities, what are the areas where telehealth is proving effective in improving healthcare outcomes? And how can patients be made aware of both the advantages and limitations of these healthcare advances? We look forward to discussing this throughout this morning's conversation. But before we begin, a few quick housekeeping notes. In addition to our audience here, we're also live streaming at thehill.com/events. Please remember to turn your phones on silent, but we do encourage you to join the discussion on social media. You can follow us on Twitter at The Hill Events and comment using the hashtag TelehealthTalks. We're going to be taking questions from the audience at the end of each conversation, so please do be on the lookout and raise your hand high so that members of our team can come and bring you a microphone to ask your question. Finally, we hope that you do find this conversation informative and interesting, and we want to hear from you, so there is a short feedback survey for you to complete at the end of our programming. So we're going to go ahead and get started. Please join me in welcoming to the stage this morning Senator Bill Cassidy, a member of the Health, Education, Labor, and Pensions Committee in the Senate, and Congressman Buddy Carter, a member of the House Energy and Commerce Health Subcommittee. As a physician, Senator Cassidy has nearly 3 decades of experience providing care for the uninsured and underserved patients in Louisiana and has advocated for telemedicine. Congressman Carter has introduced legislation in the House which seeks to improve access to telemedicine, citing the millions of Americans addicted to opioids, particularly in rural communities, who he believes would benefit from telemedicine technology. Joining them on stage this morning is my colleague and the Hill's editor-in-chief, Bob Cusack. Bob, the floor is yours. Thank you.
Thanks, Katie. Thank you for joining us in a very busy week. Congressman, I want to start with you. How does you're both doctors, how does your experience as a pharmacist influence your work on telehealth in Washington, and what does Washington need to know about actually the practice of medicine?
Well, first of all, I feel like I bring a unique experience to Congress. I'm currently the only pharmacist serving in Congress, and there hasn't been a pharmacist in Congress for many years. I'm a member of the Doctors Caucus. Quite honestly, I had to elbow my way in there. They weren't used to having pharmacists on board, but I'm very glad to be in there, and I'm in like Flint now, I might add. But nevertheless, this is something that's very important for me, particularly, not only because of being a pharmacist and understanding how important compliance is, how important access to health care is, but also representing a generally rural area. I represent South Georgia. As many of you know, Georgia is really described as being 2 states, Atlanta and then everywhere else. And it truly is that, particularly when it comes to health care. And we do suffer in South Georgia from having a lack of quality, our lack of physicians. And that's something that we've tried to answer, and we've been somewhat successful through telemedicine. And that has helped us tremendously. So I feel like having both those experiences, that of being a pharmacist and understanding, years of practice and understanding how important access to health care is, how important compliance is. 20% of all prescriptions, of all new prescriptions, aren't filled. I mean, 20%. And 50% of patients are not taking their prescriptions correctly. I mean, these are things that, simple things that if we could fix, that would just add so much to our society, a more healthy society, more healthy constituency. All of that would help us tremendously.
But along those lines, what can policymakers do to help that situation?
Well, I think what we can do is to remove some of the barriers, particularly as it pertains to access to telehealth. One of the things, I serve on the Energy and Commerce Committee and on the Health Subcommittee. One of the things that we are concentrating on in Energy and Commerce is rural broadband. I mean, having the ability to utilize telehealth in the rural areas and having the access to the broadband is essential in order to have this. So those are the type of things that I think we can improve on.
Senator, the evolution of telehealth, being a physician, what are some of the success stories? How have you seen the delivery of health change over the years?
So I used to work in a hospital for the uninsured, and among the folks we took care of were inmates. And prisons are oftentimes remote, and to get into a prison, you have to go through multiple layers of security. So you end up spending 2 hours getting there before you see a patient, and then 2 hours getting home, which is really wasted time. So if you think about evaluating a patient, there's several aspects to it. One is speaking to her, okay, or in the case of the inmates, more often a man. You speak to him. What are your symptoms? Tell me how you're doing with the medications. Another is touching them. Let me feel your liver and see if it's enlarged or small. And then the third, so the first is kind of an intellectual quality only. The second is an intellectual with kind of physical. And then the third is, if you will, machine. So where the doc and the patient are maybe interfacing through an image or through a machine. Telehealth really works in the intellectual. So we used to treat patients for hepatitis C. My nurse practitioner would stay in Baton Rouge. She would look at the screen. Here would be the patient who had committed some heinous crime and would be on hepatitis C medicine. And my nurse practitioner, so to speak, would say, okay, how are you doing on the medicine? Are you having nightmares? Are you sleeping well? Do you have a rash? You have a rash. Show me the rash. And the nurse sitting next to would hold up and show the rash. And so that's one thing that we have already done, which is really good. We're extending that, if you will. So for stroke prevention, somebody goes to a rural hospital. There's not a neurologist. They need to give a clot buster for an occlusive stroke, a blood clot that is causing a stroke. Telemedicine allows the intellectual to come in, and the pushing of the scope, if everything is indicated, the pushing of the medicine, and the clot breaks up. So again, another intellectual interface. The physical is not so good. My staff was telling me, I have a neurosurgeon who's doing a fellowship with me, so there's a robot at UCLA which has a camera fixed onto it. I think of, I'm old enough to remember Will Robinson. And it goes up to the patient, and the patient can actually squeeze the robot to give a sense of how strong the patient is.
Okay.
Now that's a physical exam of sorts, but it's a clunky physical exam. And then the last is interfacing through an image. I was at a TV station, and they don't have folks behind the camera. They just have somebody you don't see directing the cameras to move. And then I went to my eye exam, and I had that slit lamp move around. I thought, my gosh, you can have an automated slit lamp. I just sit there and look beyond, and it's kind of going to sit there and do everything for it. So I can imagine that is the next phase, where that sort of minute delay of the internet doesn't impact, and you can have the machine interface in another form of telehealth. So.
You have a white paper, New Ideas to Make Healthcare Affordable Again. Is affordability the biggest problem in healthcare right now?
Oh yeah, totally. I mean, it's always been a question of the three goals, which is access to high-quality medicine at a sustainable, affordable price. And Obamacare went after increasing access to quality medicine, but really, if you look at the affordability, when people are paying $50,000 a year for premiums after tax dollars, it's clearly not affordable. And you can say, well, it's subsidized. Well, that just means the taxpayer is paying $50,000 a year. That is not affordable. So we've got to figure out how to lower costs. One way, by the way, going back to the neurologist, telehealthing, if you will, into a distant ER, that lowers healthcare costs because that patient now has access without a helicopter ride and will avoid all the post-stroke complications with all the therapy required, the ability to return to productive work, because telehealth allowed a medicine to be administered which otherwise could not have been.
Congressman, you have legislation with Sherry Bustos on telemedicine and how can that legislation help deal with the opioid epidemic?
Well, first of all, we all know that we have an opioid epidemic in this country. It's something that we've worked on in Energy and Commerce. In fact, we put together, I believe it was 58 bills and packaged them together
Big
in
deal
HR
this week,
6.
right?
Yeah, and now it's in the Senate, and I hope that we're going to get it voted on tomorrow. And then get it on the president's desk, get it signed into law. We know that 115 people every day are dying as a result of the opioid epidemic, and it's probably more than that, to be quite honest
Right.
with you. And when we got to get over that stigma of people being addicted. I mean, this is something we've struggled with as a country, I think. These are not bad people who are addicted. They're people who have a disease, who need help, and we need to help them. But the legislation that we were talking about, there was legislation passed in 2008 that was the Ryan-Haight Consumer Prescription Protection Act, or whatever it was. But nevertheless, that was good legislation, and arguably it served a useful purpose, and that was to say that in order to get a prescription, you had to have a physical exam or had to see a physician physically before you could get that prescription. And what it was aimed at when targeting was the people getting prescriptions over the internet without seeing a doctor first. Unfortunately, one of the side effects, if you will, of that legislation was the fact that there was, a clause in there that said that the Attorney General could have waivers put in for certain situations, for special situations, but that has not been implemented. So what our legislation simply does is to direct the Attorney General to promulgate the rules by which waivers can be given. This will give the opportunity for physicians through telemedicine to actually prescribe controlled substances such as what we use in medication-assisted treatment, and it will allow them to, without seeing the patient first. Now that could be very advantageous and help us if a doctor can write for a buprenorphine without having to see the patient first. That's what the intent of our legislation is.
Mm-hmm. Senator, as far as patients, most patients have problems, obviously, as they get older.
You speaking to me, man?
Are patients, are they embracing new technology because old habits are hard to break?
I think the patient will embrace insofar as the physician is able to. You have to stress the patient-physician relationship. Or the patient-optometrist relationship, or the patient-therapist relationship. And the provider can bring a great deal of comfort to that relationship. So going back to the experience we had. Now, inmates are used to being treated a little differently for obvious reasons, but they had such a great relationship with the woman with whom I worked that they just felt connected with her even though it was through a video camera. And I find that when you have a really positive provider-patient relationship, that is the case. And the patient will go along with you. Simple answer, I think yes. And I think that it isn't age. I think it is the nature of the provider-patient relationship that enables.
You mentioned Obamacare earlier. If the map, as you know, in the Senate is pretty Republican-friendly, a lot of Democrats are defending their seats more than twice what Republicans are. Should the House stay Republican and the Senate picks up actually +2 Republicans, do you think that your party will revisit repealing Obamacare?
You know, if you want to go there, we'll say that when the Republicans repealed the individual mandate, which Americans hated, effectively that's what most folks identified as Obamacare. So that in that sense, we have successfully done that which people considered most offensive about Obamacare. The long arm of the government grabbing you and telling you had to buy something you could not afford or else you would be penalized. And unlike the folks who are on the left saying, oh my gosh, premiums are going to skyrocket, for the first year since Obamacare was put into existence, premiums did not rise on average in the individual market this year. So, boom, the mandate. Now, on the other hand, we have folks who cannot afford $50,000 a year premiums. I raised that figure once, and Washington Post did a fact check on me, and they said, yeah, he's right. You know, that's true. That's happening. And so we've got to do something there. I'm hoping Democrats will move beyond, oh my gosh, we can't afford anybody to do anything about Obamacare, and say we've got to take care of that middle-class family who can't afford insurance, who effectively do not have access now because they cannot afford. If they are willing to partner with us, we can do something incredibly positive for those patients. And if not, they'll continue to be just collateral damage over an ideological war.
Congressman, you said you noted that you're a member of the GOP Doctors Caucus, though I guess it was tough getting in. But how often do you meet, and what do you do?
Well, first of all, we meet at least monthly, and
Okay.
sometimes twice a month, and you know, it really has evolved into what I think is a very useful and productive component of what we're trying to do in healthcare and what we're trying to do in the legislature. We have different speakers in. We've met with the Surgeon General. We've met with CMS Director, and we discuss certain things that are important to us and important to our constituents, important to the committee. Those are the type of things that I think we can have a lot of productive discussions with. Not only that, but we've had leadership actually come to us and ask us our opinion and ask us to formulate policy, if you will, for what we should be addressing in Congress.
Senator, I want to get some news of the day. Big day for Brett Kavanaugh. Are you confident that he will be confirmed?
I think so. If you look at Kavanaugh's record, it has been sterling. And now we have a strategy, a tactic of let's just smear and use innuendo to create doubt without anybody ever coming up with concrete proof. Dr. Ford is obviously the one who is testifying today, about 2 minutes, a 2-minute experience. And she has named 4 people, one of whom was her best friend, all 4 of whom deny that the party took place as she described, including her best friend denying this. So at some point, it is going to be Dr. Ford against 4 people, including her best friend, about an event 36 years ago. And so none of us would wish to be judged by that standard and judged guilty because really at this point it's innuendo. And you can see the tactic. The tactic's evolving into a strategy. One more person, Michael Avenatti, oh my gosh. Michael Avenatti. Now we have Chuck Schumer and Michael Avenatti as a pair. Trying to destroy a man because they disagree with his policies. I just think it's a really bad way for our democracy to go. It's an incredibly destructive tactic and strategy.
In a few minutes, we will open it up for questions, so think of your questions. Back on healthcare, what can the healthcare community do? I mean, healthcare is such a battleground. It's a polarizing fight usually. There are exceptions. The Cures Act a couple years ago, opioid legislation, where there's a lot of bipartisanship. But what can the healthcare community and stakeholders do to really just improve healthcare as a whole?
You want me to go first?
Yeah, sure.
So one thing, you mentioned our white paper, How to Make Healthcare More Affordable. And that is a working group of 3 Democrats, 3 Republicans. There are people of both parties on the other side of the chamber, of the Congress, who are interested in the same thing. And it's things that we can agree on mutually as to how to lower the cost of health care. Now, if our problem is the cost, we've gone after quality, we've gone after access, but now cost is making access to quality medicine, is eliminating that. If we can lower the cost, we can do something positive. One thing that we just did, and how the House passed it yesterday, was the gag clause, where a pharmacist would be told by a PBM that the pharmacist could not tell a patient if it were cheaper for her to pay cash instead of paying her insurance copay. And if the pharmacist did tell her, then the pharmacist would lose their contract with the PBM. A coercive contract working against the patient. We've eliminated that both on the federal level as well as in the commercial insurance space. Now that is one start. We have other things to do. But if we just go after the high cost of health care, boom, 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 it's bipartisan, hopefully we can find a way to move forward to even more global issues, but don't underestimate what something like price transparency would do to lower cost. You can go to one, under current law, if you have an urgent care center operated by a hospital, within 30 miles of the hospital, so 30 miles away, it can charge rates similar to a hospital outpatient department, which means there might be a $500 fee just for walking in the door. Next door could be an urgent care center run by a couple of docs. Same service, that it's $50. Here it's $550, here it's $50. The patient doesn't know until she's billed. If we had price transparency, think of a French restaurant. Oh my gosh, this is what it cost. Oh, over here, this is what it cost. I'm going to go here. We need to have the patient to have that power. I can give example after example of how price transparency could lower cost and preserve access to quality medicine.
Congressman?
I would concur. The key is transparency, particularly when it comes to prescription drug pricing. Listen, we've got middlemen out there, PBMs, pharmacy benefit managers, who are simply not doing justice to healthcare at all. You ask what is their mission, and you look at their mission statement, and it will tell you it is to lower drug costs and to control drug costs. Well, how's that working out for you? Why are we talking about it if they are doing their job? They're not doing their job. We had the opportunity when I served on the Oversight Committee a couple of years ago. We had the problem with EpiPen being so expensive, $600. And, we had the CEO of Mylan Pharmaceuticals there. And here's the pharmaceutical manufacturer. That's the beginning. I'm the pharmacist. I'm the end. She's the one. They're the company that makes the medication. I'm the company. I'm the last one to dispense it. And I ask them, okay, when it leaves you, how much does it cost? Well, it costs $150. Now, I believe her. I have no other choice but to believe her, and I don't think she would tell me wrong. Well, when it gets to me, it's $600. What happened in between? What happened in between that $150 and that $600? She doesn't know. I don't know. Nobody knows, because it's such an opaque system that we don't know what's going on there. All we're asking for is transparency. And I will tell you that the most significant and the most immediate impact that we can have on prescription drug prices is to have transparency within the drug pricing system. That's what's going to bring healthcare costs down. I am a strong advocate for competition. I believe in the free market, and that's what we need in healthcare. People say, oh, you want to take away our healthcare? No, not at all. I just want to see us have competition in healthcare. I was an independent retail pharmacist. You want to talk about swimming with sharks? Now, let me tell you, that's tough anymore. And it was tough when I was going through it. But that's what we have to have as competition. And I'm not just talking about pharmacy. I'm talking about healthcare in general. How many physicians do you know anymore who just go out and hang out their shield? Most of them are affiliated with the healthcare system or a hospital system, which is fine. But what happens is that you have a decrease in competition, therefore you have less people competing, means higher prices generally.
Can I add something to what you said?
Absolutely.
So Consumer Reports had secret shoppers go out and look for drugs, 7 different generic medicines, and they found for one generic medicine, now this isn't a PBM, these are the pharmacists, for one generic medicine there was a difference in price, for cash price, okay, you're not insured, you're paying cash, and you don't have a backup plan, no negotiated price. The cash price varied from $44 to $700 for a generic medicine, $44 to $700. And it was the chain pharmacies that were $700, which tells me that they had figured out through all their algorithms that the people who come in without insurance are least likely to shop around. It was the independent pharmacy and some online stuff that was actually the cheapest. So if we had an active way to publish the price, send out a mailer. If you're on statins, this is what our cost is. Then you would begin to drive down costs. By the way, these are uninsured patients paying $700 when the cost basis was $44. That is not power to the patient, that's power to the vendor, and that's not where we need to be.
Can I add one thing to that? Thank you for mentioning the gag clause, and of course that was legislation that I introduced in the House, and
I
we
introduced
passed
that
it.
in the Senate.
I know. We accepted the Senate's bill. So. You got to let the lower chamber have a win. But nevertheless, the gag clause. We had an example within our committee, within the Energy and Commerce Committee. One of our members on the other side of the aisle, one of our Democratic members, gave an example of where she went into the drugstore to get some medication for her husband and was told the copayment was going to be $1,300. She had the knowledge to ask the pharmacist, well, if I pay cash for it, how much will it be? $40. Now, folks, there is no legitimate reason whatsoever there should have been that significant of a difference. That's why this legislation I'm so proud of. We passed it out of the House yesterday, and now it goes to the President's desk to be signed. This is going to help. And this is what we want to do in pharmacy. I mean, we're trained to help patients, and physicians are trained to help patients. And if they don't have access, if they can't afford their medications, then I don't care how good the medication is. It does them no good whatsoever if they can't get it.
We'll open up to questions from the audience. If you have a question, please raise your hand and identify yourself. And we have people with mics.
Good morning, and Congressman, thank you for your work on the Ryan-Haight Act. My name is Jonathan Evans from Novotel Telepsychiatry. That has been a significant hurdle, the Ryan-Haight Act, for us to get our addictions-boarded psychiatrists into clinics. We have a real opportunity to do that. What could we do to help you get that passed? Because I know there have been attempts in the past. I've had endless meetings with the DEA over the last 3 years, and we cannot get any traction with them. So what could we do to help you?
Well, certainly the legislation has passed now, and it'll go to the president and to be signed, and I think it'll be signed. This is very important because, as you know, we have a shortage of psychiatrists, and in this country we have a shortage of physicians. You know, we have these primary care deserts that are so prominent, and why I'm so excited about this is it's going to give the opportunity for physicians, particularly for psychiatrists and mental health practitioners, to actually prescribe these medications without seeing the patient first. And that's going to help us tremendously, particularly in the rural areas. And you know, I've always described the opioid problem as being twofold. First of all, you've got the problem with the number of prescriptions, the number of pills, and how do you control that? Well, that's something you can kind of get your arms around. You can kind of control. The second part of the problem is, what do you do with these 2.5 million people who are currently addicted? They're not bad people. They're good people. We just got to help them. That's why this is going to help so much. And this 2.5 million people, if we can get them back active in society, our unemployment rate is low. They could help us in our labor market. They could help us so much, and we need them. And we want them back as active and participants in our society. So this is just a win-win-win situation for all of us. So thank you.
I'm afraid we've run out of time. Please thank our lawmakers for showing up today and talking about a very important issue. And I hand it back to Katie. Senator, thank you so much. I appreciate it. Thank you,
Senator Cassidy, Congressman Carter. Bob will be staying on for the next conversation, and we'd like to welcome Congresswoman, Doris Matsui, member of the Energy and Commerce Health Subcommittee. She is a leader on the bipartisan Connect for Health Act, which addresses a number of telehealth policies. Congresswoman, thank you for joining us. Bob?
Thanks, Katie. Thanks, Congresswoman, for joining us this morning.
Pleasure.
You've introduced bipartisan legislation on health care, which is hard to do.
Well,
and it's with Bill Johnson
Yes.
Of Ohio. Can you tell us a little bit about what that legislation would do and where it is in the Congress right now?
okay, Bill Johnson and I have been doing a lot of things together, and actually in technology, we seem to be able to work together really very well with the other side. On telehealth with Bill Johnson, and also with Brett Guthrie when I work on Spectrum. But what we're trying to do, Bill and I, is essentially to actually move forward with ensuring that we can have more access to telehealth. And the way we're doing it is that we already passed Medicare Advantage as far as being able to use telehealth there. What we're trying to do is really kind of attack the big one, which is Medicare fee-for-service, which is difficult because CMS, HHS believes that, or CBO believes that it's going to more essential, it's going to be cost more, essentially, use more services. But in fact, what we like to do is give the secretary sort of to waive certain restrictions so that he can decide what type of services can be paid for fee-for-service, reimbursed rather, and then let them decide and let the actuary decide at that point. So we feel, in essence, because that is really the big one to attack, and if we do that and move that forward, it really breaks open a lot of reimbursement issues.
what do you see in your district? What are you hearing from your constituents? And we talk about acronyms of CBO and HHS, and what do you see at the ground level of telehealth and telemedicine that's actually helping patients where technology is an asset?
Well, nowadays, technology is all around us. I mean, our personal lives, we use it all the time. And so I believe that, in essence, people want to see this more in healthcare and make it more efficient. And certainly that's one of the aspects of lowering the cost, too. And I believe it can be safe and secure and cost-saving, too, if, in fact, we allow patients in monitoring themselves, in essence, especially with chronic diseases like diabetes. And also, when you think about the fact that there are deficiencies in really reaching out to specialists or primary care doctors, and the barriers of geography and also of transportation, so why not allow individuals to really do maybe video conferences, be able to do things electronically, so that the patients themselves feel like they have the opportunity to access health care efficiently, and during the time that they can actually do it too, because a lot of people cannot have in-person care. I mean, that's just the way it is, particularly in rural areas and even urban areas where particularly older folks can't get around as much.
Sure.
So I think for Medicare in particular. And also we're looking at it in behavioral health. I think that is so important because there are some behavioral health provider shortages. And in this way, a person can contact their psychologist and be able to have a conversation or be able to be assisted in a way that is timely. And with particular behavioral mental health, sometimes you need that right away. And it's difficult to get to your healthcare provider, your mental health provider. And in this way, you can assist a person with their health care, mental health care, in a timely manner.
What is the effect of access to broadband? I mean, everybody kind of in Washington and New York and the Northeast thinks, well, everyone has access to the internet, but it's really not the case.
Yeah.
How big a problem is that?
I think it's a big problem. It really is, because we can have even in urban areas. I mean, most people think in urban areas you have broadband. Not all the time is that true, because there are underserved areas in the urban areas, but particularly in rural areas, it's difficult to have broadband out there. Carriers don't want to be there. It doesn't, it's costly.
Right.
So that's where we have to incentivize the carriers to be out there, in essence. And so that's where we're looking at wireless and things like that. And so the rural areas are really areas where we really believe broadband is going to be necessary for them to not only have the health care they need and deserve, but for economic development also.
You're a member of the Energy and Commerce Telehealth Working Group.
Oh, yes.
What are the priorities of that group, and how often do you meet, et cetera, et cetera?
It's a group that was put together by Chairman Upton when he was chairman. And it's a group of us who really look at these issues of health and technology and try to move bills forward. And we've been very successful to do that and opening up the discussion in many cases too. Because there are privacy aspects here that people are concerned about, and we do have to deal with that with cybersecurity, because we have to look at what we do as far as making sure the platform in healthcare works for this, and especially when we're talking about electronic health records, which are necessary. And that's one of the things we're incentivizing to a great degree. We have a piece of it in the opioids bill, which should be coming up this week, in which we're incentivizing behavioral health providers to use and adopt by using some incentive payments, just as we did with hospitals and doctors, and left them out as far as behavioral health. This was some time ago, though, with the HITECH Act. So it's really concerning to all of us, particularly now, that we have really addressed more thoroughly and hopefully more carefully mental health care as being on parity with physical health.
In 2017, according to a recent study, 71% of healthcare providers use some type of telemedicine tool, which is pretty good, but how can that number get higher?
It needs to get higher. I think the problem is a lot of there are problems, I think, in communicating too. We have different systems, and
Right.
they're working through that. But also, I think people are sort of concerned about privacy aspects. And I think that has to be resolved. We'd like to see something take place in HHS and have definitely some security aspect. And
You mean like a regulation or?
no, I think really having, I had a bill this, I'll introduce again, where we really have somebody at the level of the assistant secretary
Okay.
being in charge of this, because I believe that there's certain areas that people feel like they are siloed. And I really feel that we need to have an expert there who understands what is going on to assist the healthcare providers.
How can CMS and stakeholders help the situation and provide more access and work together in a way?
Well, CMS has to be much more flexible, and I think they have been to a certain degree too. And that's why we want to really have them incentivize, for instance, the behavioral health providers to really use and adopt a lot of the electronic health records, which they aren't right now. So we'd like them to do that and to really open it up so that it'd be easier to do it. Now, you can do this at a level where you can have demonstration projects.
Mhm.
And I think those kinds of things are really efficient, and they really do prove something. And both Democrats and Republicans like that, because you're looking at it to see if it proves out, and then you can expand it.
Is there a lot of news this week? But actually, the government is not going to have a shutdown. There's a
Right.
bipartisan bill, funding bill that passed, and there's actually been a lot of bipartisanship on appropriations
Right.
this year. On the Energy and Commerce Committee, what's the level of bipartisanship?
Well, I think recently, particularly in opioids, because that affects every district in this country, there's been a lot of bipartisanship. I believe where we were able to focus on the opioid crisis, what some of us would like to do is expand it even further, particularly because a lot of the payment for opioids, at least in the sense of behavioral health, is through Medicaid.
Mhm.
And we need to look at Medicaid and know that that is a vehicle which a lot of these things are paid for. And so even though we are in agreement with the fact that we have to address the opioid crisis, and we're doing things, it's still at the edges yet. We need to look at the whole situation and move forward. But it is good that we're addressing it. And as I said, in technology, the technology subcommittee, we really do work very well together because it's more regional differences than partisan differences. And many times I represent urban, suburban area, so I work with my rural area colleagues because I've got the population and they have got all this surface area and land, and I like to assist them because I've got underserved areas, they have unserved areas, and many times we can help each other when we work through some of these things, because if we can get help for each, then we're both winning.
In a few minutes, we'll open it up to questions, so think of your questions. One of the big questions heading into the crucial stretch here, about 40 days away, midterms, is the House going to flip to the Democratic, to your party? Do you think the House is going to flip this fall?
Well, I'm not going to be a prognosticator. I would just say that I'm quietly confident.
Okay.
But listen, it's a long time. 40 days is a long time in politics, and so, we're just going to work every single day, each of us, and I'll leave it at that.
Healthcare, though, Democrats have been talking a lot this election year about healthcare. Two-part question. Number one, is it the biggest issue that you hear in your district? And number two, should Democrats win, would that be a number one, number two, number three, top three priority?
All of us are hearing about health care in different ways. Whether it's about pre-existing conditions, it's about premiums, it's about the fact that they finally feel like they have some health care and they don't want to lose it. And so it's a big issue. That and jobs, which we're addressing also. But yes, health care is something that we started out with the Affordable Care Act, and I was on the committee at the time when we wrote that. And we knew that there were, first to get access, and we had to lower the costs, and we couldn't get all of that done. So therefore, we're looking at the access part. I think we need to stabilize the marketplace. We knew how to do that, and we'll move forward on that if we take the House back, obviously. But the thing is that I believe the Republicans also understand too that health care is so very important. So we have to move forward on that and addressing the costs of health care. And I think all of us understand it's too costly. So we are moving in the way of value over quantity, particularly in areas in the Medicare. And so people understand that it's much easier or better to look at the whole continuum of care. And we started moving in that direction with accountable care organizations and medical homes, and looking forward to, as we address all of the ultimate aspects of the costs over time, and using technology, which we haven't used as well as we probably could, to use that to address some of the costs also, and the convenience. And also, I think we get better health care that way too.
We'll open up for questions in the last few minutes of this segment. So if you have a question, please raise your hand and identify yourself, and just wait for the microphone to get to you.
Hi, Congresswoman. Hope all is well. Good morning. My name is Calvin Robinson from Williamson Jensen. My question for you is, do you guys have any views on removing the restrictions of 1834M?
Which one is that one?
That one is for telehealth regulations, basically focusing on different things from originating sites, health plan shortage areas.
That's right. We're addressing that. Particular piece of it is being addressed in the opioids bill, as it is part of the opioids bill as we move forward. And it really is, right now, just for the opioids, we'd like to expand it out further. And that's part of what we intend to do. This is part of, having some of this lifted by the Secretary of HHS, waive some of these conditions. And so we believe we're making progress in that area, and the originating sites and things like that are the first step.
Other questions? How has it been working with the Trump administration on health care?
Well, I haven't necessarily been working with the Trump administration on health care. I've been working with my colleagues on the Energy and Commerce Committee.
Right.
And, it's been interesting because there's been a lot previously, all the repeal and replace. That never happened, really. They did the repeal, but they never did replace, and that didn't pass anyway. So, I think it's been quieter, so we have been focusing on the aspects that we can work together. And I think that's really very important. And understanding that there are aspects of it where, in fact, I mentioned Medicare and Medicaid. And when the opioid crisis came about, which is interesting because in my district, we had a crisis maybe a couple of years ago addressing it. But it didn't come that way in the rest of the country. So it's particularly in the Northeast and the East, it started really taking hold.
So in your district, it didn't really hit?
It did hit, but it hit earlier.
Okay.
And a lot of us coming down from China through Mexico, but we were addressing it as quickly as we could. Not that we don't have a crisis or it's all gone. It's never gone. I mean, I think those are the kinds of things we really have to continually address. I mean, we know with healthcare, nothing's ever completely done. And it's one of the things is that you never know what's going to come up next, whether it's that, it's Ebola, whatever. So therefore, I think particularly in energy and commerce, we did get involved in many, many things. And the aspects of what we're doing are really relevant to what's happening today, whatever it is. And because of that, we seem to be able, we had some problems with health, but because everybody had the same situation, we're able to work together. And also make some reforms, to start to make some reforms, in particular in areas like Medicaid and Medicare, as you brought up. And hopefully we can use that to move forward, because they're somewhat like, to a certain degree, they're like demonstration projects on their own. Yeah.
You mentioned affordability and working with Republicans, and Republicans see that there are problems, as the Senator and Congressman Carter mentioned in our last panel. Do you think, whatever happens in the election, that there could be, let's say outside of opioids, let's say outside of Obamacare, because that's going to be difficult, that there could be some work on prescription drug pricing
Oh,
or
yeah.
anything like that? You
No.
think there could be bipartisanship on that?
I hope so, because that's what comes up an awful lot, the cost of prescription drugs.
Mm-hmm.
And that's where a lot of costs are really particularly a problem. And so we're looking at prescription drug costs, particularly in Medicare.
Mm-hmm.
And we like to see, Medicare use its leverage since it's got 40 million people,
Sure.
beneficiaries, and they all use medications. So if we can use that as a bargaining power, I think it'd be great, because I think everybody knows if when Medicare moves, the rest of it moves too.
That's an issue that President Trump has mentioned, at least on the campaign trail, but critics say he hasn't done much.
Well, I haven't seen too much in that, so we're really looking at it and trying to figure out. A lot of it is layered too. You can't tell sometimes when one adjusts one way, like can go down one way and then they pick up, it's costly another place. So it's a complicated issue, but it's one of the top issues for all of us.
What about single payer? Would that be a top priority for a House Democratic-controlled chamber?
I think that's more, through some of the states. I mean, the way I look at it, I believe in universal health care. So how we get there is going to be maybe, we'll look at, see whether we want to have buy into Medicare, Medicare for all. We're not there yet. Just recall, even though we're not talking about Affordable Care Act, at the very beginning, we had a public option, right? So we understand what steps we might want to take in order to get to universal care. But it is something that we're talking about, but we're not taking any action right now.
Just on the overall issue of funding, is that something that healthcare needs more funding, and would it be taxes? I mean, some people are saying the tax cuts need to be repealed. Some Democrats are saying that.
Well, I think if you look at the whole system, there are places that we can reduce costs, right? And I think we have to look at that. I think we need to look at the marketplace and make some adjustments there. And I also believe that we need to ensure that Medicare and Medicaid are stable. I think that's really very important, because that provides so much of the health care of our nation. But I'm not going to say right away we have to add money to the system. I mean, I think we need to balance this thing out, because there are things in the system right now, like we're talking about prescription drugs, that we need to squeeze some efficiencies out of right now.
Well, thank you for joining us this morning. Please
Thank
thank
you.
the Congresswoman.
Thank
I'll hand
you.
it back to Katie. Thank you so much.
Thank you, Congresswoman Matsui and Bob. Now it's time to hear from our sponsor. I would like to welcome to the stage Peter Menziuso, President of the North American Division of Johnson & Johnson Vision Care. He is also the co-chair of the Healthcare Alliance for Patient Safety.
Thank you very
Thank
much.
you.
Thank you today for the opportunity to present on behalf of Johnson & Johnson Vision, as well as the Healthcare Alliance for Patient Safety. The speakers today are already driving some very thought-provoking thoughts in the space of telemedicine, and I'm looking forward to the upcoming panel post my discussion. What I can tell you already is it's very important that we're having this conversation. There are places that we're absolutely aligned on the benefits of telemedicine, but there's also conversations that we have to have in this space where there's differences, and we'll talk more about that in the course of today. The one thing that we must agree is, for years, we've been talking about telehealth and telemedicine coming into the space of healthcare. It's here already. We talked earlier, you heard some of the panelists talk about behavioral health for patients in rural cities that are taking counselors through conversations in behavioral health. School nurses are using telemedicine to help access routine care for illnesses in children, and they're saving parents from the need to go to their pediatrician or even going to urgent care. People that are living with tuberculosis are uploading videos, and they're sending their daily medication routine to their physicians to demonstrate compliance. For all of us that are gathered here today, we know that telehealth has remarkable potential. It can empower people who otherwise would be unable to access health care. It can enable people with both chronic illnesses or terminal illnesses to check in with their providers without ever having to leave their homes. Telemedicine also can cut back on unnecessary trips to the emergency room, and they can allow providers to quickly diagnose who really needs more comprehensive in-person care. But of course, like any technology, all technologies, especially telehealth, must be used in a very prudent way. Telemedicine can absolutely increase the ability for access to healthcare. It can lower healthcare costs, and in some cases, it can even improve outcomes. But we must be sure that the patient's health is never compromised in the name of convenience or cost savings. So today, I'm really fortunate to be representing two esteemed organizations. First, Johnson & Johnson Vision Care, where I serve as president for North America. And since our introduction of the AccuView brand contact lenses and the world's first soft disposable contact lens in 1987, we have passionately been pursuing new technologies that are meeting the highest standards of care and also driving unmet needs for patients. We haven't stopped since that introduction. Over the last 30 years, we have consistently been on the forefront of eye health technology, most recently with our evolution into broader eye health. We're looking at solutions that can help a patient along their lifetime of journey of needs in the space of eye health. But we know that the advancements are not possible without keeping two core principles in our organization and our innovation agenda. Patient eye health and safety are a must. Now, the Healthcare Alliance for Patient Safety, of which Johnson & Johnson is a founding member, also holds the same principles to be true. I'm pleased to be here to present remarks as a co-chair of the Alliance. The Alliance is a leading voice for patient health and safety. It's comprised of health advocates, innovators, trusted health experts, all in the eye health community. And there are 5 key principles that are guiding the Alliance. The first is the preservation of the doctor-patient relationship. The second is making sure that as we prioritize health and safety of patients, we also look how healthcare technology can advance in that space. Third, we want to ensure that when a doctor is writing a prescription for a patient, that prescription is written as honored. Fourth, it's ensuring that today's regulatory framework promotes patient health and safety, and that it's also enforced. And fifth, we want to be a source for policymakers, for the general public, with information that is useful to protect patients from any type of unnecessary harm. These are the key principles that the Alliance has considered, and it's also the principles that we think about when we talk about the role of telemedicine in the space of eye health. And yes, with this potential, we're already seeing some challenges when it comes to telemedicine in the space of eye health. In some instances, convenience is at the expense of patient well-being. Some online sites are not requiring an updated or valid prescription to renew contact lenses. Others are encouraging patients to skip a comprehensive eye exam. As an eye health company, we know that eyesight is the patient's most valued sense, and it's critical to keep our eyes healthy. We must also experience the world in a way that requires us to stay very close to the healthcare of eyes. Eye health is also essential for primary care. Over 250 systemic diseases and illnesses and conditions can be detected through a comprehensive eye exam. For instance, diabetes, heart disease, thyroid conditions. And while today's telehealth technologies can help connect more people to care, they do not completely replace all of the elements of a comprehensive eye exam. We're excited to see where these technologies will evolve and advance in eye health. And as we continue down the path of technological innovation, the Alliance is working to ensure that the doctor-patient relationship stays at the center of care. As we see this as a key component to ensuring that patients are receiving the highest level of care, that they're taking advantage of telehealth as it meets and fits in their needs. Not everybody sees it this way. There are some states that have proposed to remove the provider out of the eye health equation and in this process potentially putting patients' eye health and safety at risk. That's why, as telehealth initiatives advance, we must ensure that patients receive the same high standard of care as they would as if they were in their doctor's office. At the end of the day, we recognize the world is transforming faster than we could ever imagine. Medical professionals are consistently looking at new technologies to provide better care for their patients. From x-rays to vaccines, once what was thought was novel is now routine. In this respect, telehealth is not different at all. That's why it's so important that we are having these conversations today. As we think about telehealth and its potential to improve patient outcomes and access, we must make sure that these solutions are keeping the doctor-patient relationship at the center of care. Thank you very much.
Peter, thank you so much for that. And now we're going to take a deeper dive with 4 subject matter experts to talk about the future of telehealth. For that, I'd like to welcome Dr. David Cockrell, owner of Cockrell Eye Care Center, Samantha Zenley, Senior Regulatory Policy Specialist, National Council on Aging, Susan Poland, Public Affairs and Advocacy Associate Executive Director for the American Public Health Association, and Natasha Sukolyevich, Executive Director of Telehealth at the University of Pittsburgh Medical Center. Joining them is the Hill's healthcare reporter, Peter Sullivan. Peter?
Thanks, and thanks again to everybody who joined us. Now we've heard from our lawmakers. We're going to dive a little more in with our panel to talk a little more. So, Natasha, I thought maybe I'd start with you. I mean, obviously working at UPMC, have used telehealth. Maybe you can just talk about, just start us off with kind of the benefits you've been seeing, how you guys have been using it on the ground there, and how that's been working for you.
Sure, Peter, thank you, and happy to share our story. So we've been engaged in telehealth since late 2006, early 2007. Started out with what we heard this morning, the use of technology to be able to access patients that come to community hospitals, to the ED, and that have a neurologic event that is presumed to be a stroke event. And through the leadership of our chair of neurology, Dr. Larry Wexler, he saw the vision to be able to deploy his team that wouldn't be able to come in person to these community hospitals, and instead to access his expertise and his team's expertise remotely through the use of technology. We now have over 30 locations, more non-UPMC owned hospitals than owned hospitals throughout various communities across Pennsylvania that we provide telestroke services to. So as you can think about, so that was a game changer for those patients that didn't have to be transported past their local community hospital. And then the key too is that they can remain in that hospital, so they're closer to their families, they're closer to what they're familiar with. So that was our first segue in. And then behavioral health, which is something that was mentioned earlier today too. Huge need across the country, so we were able to use telehealth to reach many more patients across the state that needed behavioral health services. From there, we evolved and we started looking at how can we also expand access in areas where there may be subspecialists that aren't available, where patients are remote enough that the drive time is a heavy burden. And we developed what we branded as our UPMC teleconsult centers, which are basically virtual multi-specialty clinics in these communities. And through those types of access points, we've now been able to see over 7,000 patients. We have over 32 subspecialties that are delivered remotely. And cumulatively, the impact just on transportation alone has been close to $900,000 in cost savings. So as you can think about, that evolution, what the impact means to access to efficiencies, we're a large system that continues to grow. And so it allows us to leverage our subspecialists more efficiently, and it allows these patients who we evaluate in terms of their satisfaction and ask them, what would you have done if this wasn't available? Well, interestingly enough, about 30% say that they would have foregone care altogether. So it's a game changer in terms of continuity of care and being able to manage patients with chronic conditions and oftentimes multiple chronic conditions, looking at what the outcomes are clinically and minimizing those acute events that can be avoided. We now also have a direct-to-consumer app that's on your smartphone, tablet, UPMC Anywhere Care, that's available to anybody across the state of Pennsylvania, that gives them basically access to a provider in their pocket. So it's bringing that doctor back into the patient's home where and when they need care or need to communicate with a provider. And we continue to grow with remote monitoring. So all these various use cases that you often hear in the telehealth space, we've had the opportunity to both test, expand, and integrate into our care continuum. So with that, I'll turn it over to one of our
Great,
colleagues.
Thanks for that. I guess I'd maybe go to Dr. Cockrell as well. You're also someone who's practicing using this. I mean, how have you been using it, and what kind of benefits have you seen from telehealth?
You know, I've had the opportunity to participate in telehealth in Oklahoma for about 10 years, and from a variety of different avenues. It initially started with diabetic care. We have a large Native American population in the surrounding area. We provide care for multiple Native American reservations. And so because of the significant number of diabetic patients there, that's where telehealth started. Telehealth has its promise and it has its challenges. And the promise is immediate care, as Natasha talked about, and immediate consultation. And I think the thing that we've got to keep foremost, and what we've certainly seen in the populations I've worked with, is having the doctor-patient relationship first. Telehealth doesn't take the place of that. When it comes to long-term systemic care, as we manage diabetic retinopathy, for instance, it's having a physician doctor-patient relationship where somebody's intervened, where it's not just someone looking at a scan. And so it's got the promise of delivering that, which we've seen it deliver. We've seen a decrease in the rates of non-proliferative diabetic retinopathy transition into proliferative diabetic retinopathy over time, as we've been able to bring a specialist in at an earlier point in time. The challenges are that there's many different telehealth platforms that we all have to decide. Is it going to be live interactive? Is the physician or the nurse practitioner or the PA going to be talking to that patient one-on-one in a live time? As the senator said this morning, you're looking at the rash on their arm, right? That's live. Is it going to be some type of store forward information where the scan's taken and saved and then is sent forward to some physician or some other practitioner to look at and then comment back? That's more of a consultation problem. And then also then just remote monitoring. And so all those come into play and they all work quite well. The challenges I've seen is, the biggest challenge I've seen is that the doctor-patient relationship. The second one is just the credentialing privileges. As we've seen some of the nascent programs roll out in Oklahoma, and we're far behind where she's talking about, is a credentialing aspect and the privileging aspect that has to take place for that doctor, me, having the credentialing privileging to provide that care. I was asked to participate in a panel to look at some of the care for reservation in Mexico. Well, I'm not licensed in Mexico, so I've got to be licensed in that area. If I'm actually going to be if I'm a consultant, that's one thing. Maybe my licensing and privileging is different. But if I'm going to directly intervene, then I've got to be licensed in that state, because there's the downstream situation of who's got responsibility and liability, right? Yeah. So we've got some of those challenges to work out from a physician standpoint, but I think it's very promising. From an eye care standpoint specifically, I've seen it work well. I've seen it work poorly. And you know, I've got a young man that's going to see a neurosurgeon today that's 3 years old that started out as a telehealth patient that I insisted on seeing in my office as opposed to that. As it turns out, he's got some particular type of brain tumor that started out truly as a telehealth patient. So that's the downfall if you don't have that physician involved, that maybe care is delayed longer than it should be.
Right, yeah, that's it.
Should have gone
That's
that
a
way.
good,
Yeah.
that's a great ending.
So right, we've talked about, you know, there's some you could even start off in telehealth and then it can evolve, but I mean, there's some instances where you kind of need to be there. So maybe Susan, to talk about some of what do you view as kind of the limits of it sometimes? I mean, are there cases where you just really need to see someone in person, and what are the cases where maybe it does work better to have telehealth?
I'll start with the places where it does work, because our focus really is on prevention and moving upstream. And so there's lots of opportunities in all of these different programs where interaction with the patient can minimize their need to go to a doctor's office. And for people who have limited abilities to travel, who have limited transportation, it's a great opportunity to expand access, and that's really important. But you can't give a flu shot through a telehealth process, and you can't necessarily create communities that are walkable and that offer opportunities for health. And so there's really huge steps forward that we can make in terms of clinical care, but in terms of keeping people out of care and keeping people healthy, there are obvious limits. Yeah. And what it can also do, though, for people who have chronic illness, is it can minimize secondary impact, and that's an important component as well.
Mm-hmm. And at the National Council on Aging, I think you bring up a good point about minimizing secondary impact. Telehealth has a huge promise, as the word that we keep using, in chronic disease self-management. And so like you said, there's diabetes self-management programs that you can do online. I think that all these things that we're seeing as challenges in terms of how do you deal with licensing issues, or how do you deal with different types of technology, these are issues that people are working on right now, and there's an evidence base for diabetes and these diabetes programs, and organizations like ADA and the American Association of Diabetes Educators, they are committed to these programs, and they have licensing standards set out for these programs. So I think, sometimes it's a case-by-case situation, but there's a lot of smart minds working on these issues. To me, the real issue actually in telehealth is the access problem in terms of the disparity you see, and this conversation was brought up earlier in terms of broadband, and that the folks who really need it out there are the folks who don't have it.
Mm-hmm. And I mean, how have we seen, I guess from the patient's perspective, especially if you're an older person, I mean, do we find that the patients are usually, accepting of this or into this, or are some people saying, no, I don't want to see my doctor through technology?
I'll comment on that for a minute.
Yeah.
We've got obviously a rural patient base, we've got an elderly patient base as well, and so we see some of our older patients that don't have the technology at home to be able to do it from a home-based situation. If they can go into one of our local communities and avail themselves of technology, we can have that interaction face-to-face. Broadband is a huge issue in rural America, as the representatives talked about earlier. Mm-hmm. The technology is just not there. And then trying to get the technology platforms to talk to each other is also a challenge. Mm-hmm. There's so many different platforms out there. So what I find is our older patients, we participated in a small research study on diabetic care a couple of years ago, and our senior patients were the ones who truly had trouble actually just getting online and filling out the information, just simple filling out the information to give us back for the research itself. So it's a challenge from technology, it's a challenge from integration based upon comfort with the technology.
So the good news is that there have been a number of vendors, especially in that remote monitoring space, that allow you to have a very simple tool, a tablet that is then deployed. So you give that patient the tablet, you set them up, you make sure that they know how to answer the questions. The questions can be as simple as click on the smiley face, the frowny face, how are you feeling today? So there's ways, I think, to integrate and make sure that it's simple enough for anybody to use. And so I think that these are challenges that are being overcome and in some cases have already been overcome. And we don't see a lot of resistance, I think, based on age. Most of us today, regardless of age, have some sort of cellular phone that we carry with us. Mm-hmm. So even if you can deploy the phone, if they don't have a desktop computer, that's an opportunity to embrace, and I think that there's technology that's available that can be then leveraged, and so much of the growth, technology has always been ahead of where we are in terms of operational adoption. We still see barriers with reimbursement. We see in Pennsylvania, we have a Senate bill right now that's in front of the legislative committee to vote on that would allow us to be able to be reimbursed by the commercial payers. And we're behind, so there's over 36 states across the country that have what are called parity laws, not necessarily equal parity, but it doesn't allow the commercial payers to blanketly deny coverage for a visit if it's done in person when it's done via telehealth. But Pennsylvania still doesn't have that. So that's been an issue for us. And then the other issue is the CMS definitions of rural health provider shortage areas don't always make intuitive sense. So we have areas that are over an hour and 45 minutes away from an urban location that have shortages of primary care, shortages of subspecialists. They're not designated as rural health provider shortage areas, which means Medicare, if you have Medicare, you don't have reimbursement for telehealth. So I think there's still opportunities for us to catch up. And once telehealth becomes mainstream medicine, then I think we'll start to see the adoption and the flow to really maximize the opportunities that are available.
There's another opportunity that I think we have if we train our providers correctly, which is to allow them to look at not just the specific issues that they're discussing the patient with, but to try and understand what's going on in that environment. So if you are doing an interaction with somebody in their home, you can look around. If there's an issue with mold, if there's an issue with cleanliness, it can help you understand something you might not be able to see if you're not able to actually get into the home this way. So there is the possibility to create that old style home visit if it's done well and if the providers are trained to look beyond just the specific questions that might be on their sheet to look at the disease that they're focusing on.
Excellent.
I guess I'd add to those comments. I agree with both of them. I think technology, innovation leads technology, right? And then the adaptation of that technology is always a little bit behind as we try to figure out how to utilize it, how to get our patient base to utilize it, how to get the providers to utilize it well, and to be all-encompassing. I think, again, that's the promise of it as we continue to roll out and we see it in more areas. Eye care it works very well for when it's done appropriately and the technology matches. So I think it's an exciting time for us if we can get, from the regulatory standpoint, to come together with it, along with the licensing, along with the fee parity, along with the payment schemes that are coming online, and as we work with CMS right now, trying to help them adapt what they're going to with the function of how they incorporate telehealth.
I mean, I guess since we're in DC, I mean, if you had one thing that you'd want either Congress or CMS, to change, I guess what would any of you say? I mean, is it the payment issues? Is it broadband access? I mean, what's kind of the one thing that you'd really like policymakers to do on this?
So I'd like to commend CMS for, in 2019, removing that rural health provider shortage area restriction for telestroke. That's the first clinical area that is now going to allow patients, regardless of community, where they are, to be able to be reimbursed. So the adoption then and the barriers to these smaller community hospitals that are cash-strapped to begin with to be able to leverage, there's going to be much more incentive for them to be able to utilize telehealth. But that's one clinical area. So if we can start to leverage and look at other clinical areas to do the same thing and not have arbitrary limitations to the opportunity to integrate, I would say that would be a big resource. I was invited to a meeting in DC where the group was talking about the expansion and incentives with broadband connectivity, but then there was a question, so there's the broadband connectivity that's expanded, but why isn't telehealth being used? And I think people just think that if you have broadband, you can click the switch and somehow people are going to start using it to deliver care. I think there's an opportunity for us to adopt a model that can actually be implemented, start looking at where we do have broadband, how can we now leverage that and what's needed. So hopefully that committee will continue to work on those details too.
Yeah, I don't think you can actually forget either of those issues. I mean, we can't, in DC, we like to come up with 10 issues at once. Right. But I think that, payment and access, building off what you said, I think are tied together. So like you said, it's one program that they've removed the rural restrictions. And as Congresswoman Matsui said, you don't just see access problems in rural areas, you see access problems in urban areas. People still have to go to community centers. You see grandparents who are taking care of their grandchildren and they don't have the time component that's necessary with access to run to the doctor or go to a center to take a self-management class. There's a lot of different ways to define access, and so if CMS or Congress looks at this issue more closely, hopefully they can come up with a more comprehensive way to address that component of payment so these programs can be expanded.
Yeah, my comment would be, I think there's one thing I'd ask for as CMS looks at this is to make sure that the doctor-physician relationship is sacrosanct and that it's always part of all telehealth. Certainly it's not going to be every bit of it, but I think as long as that patient has a direct relationship with a provider that's important, you don't want to dissociate or detach from that. That's the number one thing to ask.
All right, I think we're ready for some audience questions. If anyone has a question, please raise your hand and then wait for a mic to come to you. So I see right here. And please introduce yourself first.
Hi, I'm Ellen Milheiser. I write the newsletter Synopsis on healthcare. The comment was made that provider licensing remains a problem for telehealth. I've heard the policy suggested that instead of licensing where the patient is located, that the government require the license be held by the physician, and as long as the physician is licensed in any state, he or she could provide care to a patient in any other state. DOD and VA already do this. It's, what would you think?
I'll give you the challenge to that. I also sit on a regulatory board in Oklahoma. And so in a situation where you're licensed in one state, rendering care in another state, and something goes wrong, who has responsibility and what agency is going to deal with that? And so if a provider in Oklahoma is rendering care in New Mexico, and for some reason something goes wrong and some type of litigation takes place, or some complaint to a regulatory body, if that patient in New Mexico is complaining to a regulatory body in Oklahoma, they're going to have a variety of problems to get anything done. So at this point in time, the TJC, the Joint Commission, has established a set of standards indicating that the person doing live access needs to be licensed in the state where the patient is, so the patient has a direct route to resolve a problem. That's the biggest challenge I see right there. It's the responsibility at the end of the day for that patient.
Any other questions?
Hi, my name is Seema Kazmi. I'm a pharmacist, and currently I'm serving as the communications chair for the Maryland Pharmacists Association. And my question is regarding, with some of the in-home visits and telehealth monitoring, some companies have a technician go out to the patient's home, and then the provider communicates with the technician and the patient for chronic care management services. And just wanted to know if you have any comments on that type of model.
So, can you just clarify for me? I'm sorry. I know the mic was taken away.
So some providers, let's say the provider is remote, and then a technician who is local to the patient, they'll be with the patient in their home. One of the providers had mentioned that some of the older individuals have difficulty accessing the internet and using technology. So some of these technicians, they visit the patient's home, and they'll have an iPad with them, and they'll basically facilitate that telehealth visit with the provider. So wanted some commentary on if you...
Yeah, so we haven't done technicians, but utilizing home health nurses or some of these clinical facilitators that actually do come to the patient's home, and then being able to do, whether it's a wound nurse or, again, a home health nurse when patient's discharged, to be able to follow up with them and bring that tablet. So we have done those types of things, and then they can be tied into another clinician, whether it's a nurse practitioner, a physician's assistant, or actually a physician, depending on what they're trying to accomplish, in terms of the touch base, the acuity of what they're reviewing. But I haven't heard of technicians, so I think that would be interesting. It just depends, what is that person who's at the, what we say bedside, but in the home, what are they actually tasked to do? If they're not doing anything clinically, then it probably could be a technician.
So when I was referring to technicians, so I'm a pharmacist, and I'm aware of, with medication therapy management services and chronic care management services that pharmacists provide, perhaps a medical technician or a pharmacy technician. They also call them like pharmacy assistants. They'll come out to the patient's homes and help facilitate that pharmacist consult. So
So
if that's
I've heard of it. We don't do it, but it makes a lot of sense to me because med reconciliation is a huge issue, I think, for everyone. So I believe that there are programs, and there's probably some reports that have already been published, but I'm not as familiar with them because that's just not one of the areas that we've recently focused on. So.
I think it's a good idea. I think anything we can do to pass that health information along to the end-stage provider, whoever that is, and if you've got a technician there who may be also able to ascertain, as one of the other panelists talked about, the state of the patient itself, because so much of healthcare is watching that patient, seeing what they're doing, and if it's truly electronic, the provider can't see that. So if there's a technician there who can also comment on something that that patient might not say, that's going to help deliver the care. So I think it's a good idea.
There's a program in New Orleans-based health system in which a lot of what they're doing is remote monitoring. So they're using remote blood pressure monitor, remote scales to diabetes measurements. And I think that especially early on in that process, having a technician help the patient walk through and understand how all these pieces work together would be a critical piece to make sure that in any future conversation with a provider that's remote, the technology is working well to maximize the actual interaction.
One more quick question. In the back.
Hi, my name is Kim. I'm a student nurse at Georgetown. And so one of the things we've been talking about in school is, physician and provider burnout. And so we've been talking a lot about increasing access. How do you prevent, think that you could see that prevention of provider burnout, especially as we have physicians and nurses leaving the field?
So that's a great question, and I'm glad you mentioned it because, I think what we've adopted now is no longer the triple aim, it's the quadruple aim, and the quadruple, the fourth part is the provider part. So helping to not just improve the patient experience, but the provider experience. And to do that, we need to minimize the disruption to the usual provider workflow. A big piece of that has been integrating telehealth within those electronic health record systems. So for providers already in a system that they've been mandated to use on a daily basis, how can you integrate the workflow of that telehealth visit to be seamless within that in-person workflow? And so we've focused on that over the years since the beginning. A lot of the telehealth vendors separated themselves from EHRs, and rightfully so, because that was so complicated and there was no incentive for any kind of interoperability. I think the EHR vendors too have recognized that, so you have the large players that are either integrating those capabilities, have them already, and now starting to leverage them, or working with vendors to integrate that opportunity to be able to have telehealth visits pop up on a provider schedule and having you be able to click on that link then and directly connect with that patient who's connected on their end. So I think that's a big piece of it.
I think you asked an essential question. Remember I said there are promises and challenges? I mean, the workload's immense, and if you take that on, it's going to have to fit into the schedule. It can't be an on-demand while you're in the middle of your patient day. It's going to call for increased number of physicians, increased number of care providers to actually be able to manage it.
All right, I think that's all the time we have for this panel, unfortunately. So thank you, and thanks to our panelists.
Thanks, Peter.
Thank you again to everybody who joined us this morning, to our panelists in particular, and a big thank you to our sponsor, the Healthcare Alliance for Patient Safety. If you missed any portion of the discussion, you can find it at thehill.com/events. The full video of this morning's program will be up shortly. And please do fill out the survey about the event that is on your seat. Thank you all so much for joining us. Have a great day.